Again, we're having this simulation as a result of an incident. We want everyone to go with the dynamics, the team dynamics, so that will mitigate some of the issues that have transpired during that time. I invite all the participants to be in place. You would need an anesthesiologist, first assist, surgeon, and circulator.
Are you going over the two dynamics?
Yeah, I will. And then while we do that, we just want to have a brief review of the team steps, team tools, and strategies for patient safety, leadership, communication, mutual support, and what was the other one? Situational monitoring. Sorry, communication. Yes. So leadership. So as to limit, there has to be a leader, captain. Being shut down. No one wants to speak up. If they have ideas during the event, we just want someone to lead and have a good communication with the team. All cross-checking, closing out, closing the loop. So all the information, everyone is on the same page with the same information. In the end, it would create a smooth flow of information, and things could be done. Mutual support and situational monitoring. If we're being asked to support a critical event, we assess the situation and ask what help could we provide, and not crowd the area so as the flow of events can be smooth enough, and the cascade of the protocol would move forward and not be impeded. So leadership, communication, situational monitoring, and mutual support. All right. So without further ado, we can go ahead with the timeout and we'll start the simulation.
I have a question.
Yes.
What procedure we doing?
SBAL.
Okay.
Yes.
I just
So
wanted
this
to
is
make sure
a 58-year-old female, male, scheduled for SBAL under general LMA, no drug allergies, Malempati was scored 2, and a good TMD score as well, more than 3 CMs. Patient is on the bed. We'll go ahead and do the brief, timeout and the brief.
Okay, we can do the timeout. Sir, can you tell us your full name and your birthday?
John Doe,
Okay.
medical record number 458-2212.
Allergies,
No known drug allergies.
and what procedure are you having done today?
They're going to shock the stones in the right side.
Left side.
So we're going to do general LMA anesthesia. It's not an anticipated difficult airway. So, and you mentioned allergies already, no?
Yes.
No allergies. Any antibiotics?
No antibiotics.
So,
So, the only thing that I still have to add, because we don't have a scrub tech in the room, there's no need for a scrub tech in the room for these procedures. I need to add that we have all the equipment that we needed, and fire risk is 0 because we don't have any prep, any incision, any source
Okay.
for the fire.
Alright, so this is John Doe doing left SBAL, no need for antibiotics, no need for Unidines, all of our equipment, necessary people are in the room.
Patient please updated consent sign. No.
agreed. So we cover anesthesia. Oh, that's fine. Anesthesia takes place.
As soon as he starts trying.
Okay,
So one of the concerns was that you couldn't reach the patient, right?
Correct.
So is the machine too close? Because it seems like you would easily reach the patient, so I'm concerned our setup is not actual. Can you fix it?
so like in the
No, it
room,
is, because the head was over there.
Why should you put an extension?
Yeah, that's right, because if you think they're in the room,
The only difference is the patient
yeah,
will
the
always be
anesthesia machine's here, the head should be here.
She's a little further away.
okay, because I thought it was the other way, that's like the best.
Just like that.
Okay, alright.
That's a problem. And sometimes you have to put an extension, it's even further out.
Okay.
Further out.
Get out of the way.
All right, and then, all right, so assuming we induce and check, I'll ask my anesthesia tech if we can check mask the patient to see if we can mask, which are what we normally do. And then after that, try to put the element, open it. Open it. Yeah. And then,
You don't have.
so we'll just assume we try to put the element.
Yeah.
And then,
I don't think we had a tech in the room that day.
and then try to ventilate them.
Yeah,
It's not
training.
fitting, not ventilating well. And then try the different type of element, which is the iGel, which seems to fit better. And
Are you guys
even
gonna
that,
attempt?
second attempt.
How do we?
And then the problem, there was no assistant. I have to run to the machine,
No,
to bag, see if it is working.
scenario.
Not perfect.
So-
We need to intubate because SATs are now.
So just let me interject. Follow the rhythm there and do what you would do. Don't explain. Just
Okay.
go ahead and then ask for help. Go through the motion. The SAT is going down. What do you do? Not explaining, but try to go through the motion of, hey, I
Okay.
need this, I need that.
I need the laryngoscope, we need to intubate in the tube. Everything's not set up yet. Meanwhile, attempting to mask.
Can you read,
So-
Do you want me to call another anesthesiologist?
You can call me, but I need somebody to mask the patient, drag the patient from there. Because I can't hold the mask and mask.
bag?
Stay there. What do you think?
I'm gonna call 5711 for the other anesthesiologist.
Yeah, go ahead.
Calling 5711. Doctor needs help with intubation.
Still be saturated. Can I have an oral area?
Anesthesia is coming.
It's not in this
I
card.
think I'll ask Dr. Wood. Can you help out holding the mask? You know what I.
And can, Junior, can we have an oral area where?
Do you want a code card in the room? You want,
Yeah, I-
respond to the
yes.
code card.
Code card, and I assume that I don't have to ask her because it was there, but I should have.
Can
And
you
then.
get the guy called?
What you need?
Right, so back in here. Back here, with the help, the casual patient.
And the mask is not out of the
Yes, yeah. Can we put the pad in here or not? Can we put pad in?
Yes, go ahead and put
Yes,
that.
there's a pad
Oh,
already.
there's a pad.
So the pad is already there, you just have to connect it.
There you go.
Let me go around.
Where is your,
It's still baggy.
this is not the same machine you had.
So that's hanging in
This
there.
one right here, there you go, that's what I was looking for.
All right. So that's. What we should do. Let's-
Wait, I need somebody documenting, somebody document? Alright.
I'll document, I'm
Sheila, you're
documenting. Yes.
documenting? Is it on this side? There you go. Sheila, there you go. Emma, you're pushing drugs? Alright. Hannah, you got meds? Okay.
I'll
I'm
grab
available for assistance.
Do you need a second IV setup?
Yes, you can go ahead.
Got it. Have we called 911?
We have not called
Can we not
911.
see? What is that?
And,
Right?
Would you like
Glasgow.
911?
Something is called.
And can we please call ENT?
EMT?
Continue masking.
I'm so
Dr.
sorry.
Dr. Woodard, can you hold 911 please? Second line established
And what am I telling them?
at 124. Yeah, there's a
Yeah,
second
we
leader
just booked
error
her
going
way.
on.
It's
We have a
somebody
difficult
bringing the
airway
rifle.
patient.
Maybe it's getting the Glasgow.
And I need the fiber optics also.
Okay, I get the fiber optic.
And somebody already called the ENT doctor.
Yes, we also overhead page the ENT as well to
Can we
respond to
get the
anesthesia.
tray ready for
Okay.
We have a trach, you want the trach?
her? Let's get the real tray.
The trach, the real trach, we have the trach, we have the trach.
Charge nurse, we need scrub technique for the tray setup.
Yes, I will. Set up the tray. Here.
Dr. Your oxygen is still low.
Yeah, we're setting up.
I'm still back. But I don't think it's,
We have a pulse. You have a heart rate of 125, 81% O2, pressure of 79/49. Got that you? I think, yeah, but what is this?
Yeah, carotid pulse and femoral.
And femoral, you have, okay, I think I'm gonna go. Okay, that's what. Okay, I do have a pulse.
For the doctors like properly, can we increase the flow, give like bottles?
okay, Wallace is hanging.
And where's my evidence as well?
125.
Can we please call for another anesthesiologist?
Second anesthesia should be.
They already called for it, but we don't really have a person to come in the room though.
Right. Asha was here. Your second anesthesiologist is prostaglandin. There you go. Right over here. Come on, Junior.
Second assistant.
It's set right now.
You want to go?
Stop, it's still low.
And here's the bronchoscope.
Okay. And
We're gonna pretend to be ENT.
it's still, yeah,
The ENT?
SATS is still not improving.
No, it's not improving. Richard's ENT. Richard, go, ENT, come on.
Okay, me too.
We're gonna put it in the
Did anybody open the tray?
Yeah, right here, yep, we have it ready.
So we have a problem.
Yes.
Talk to me, what we got going on.
We can't intubate and we can't ventilate well. But with the LMA, we're able to get a bit of air.
Okay, can you see the cords?
No.
Even with the bladoscope, you can't see the cords.
That's what, looks like the her tongue is very large. It's difficult. Okay, the blood pressure's coming up. But the shots are still hanging there.
Yeah.
We might need,
Before I do that, let's look at what we got going on with the airway itself. Let's see what the cords look like. Let's see if I can intubate before we go with the trick, okay? I think that was a reasonable thing to do.
all right. Okay.
So would you like
For
to,
all my opinions, the more attempts we make, the more likely there'll be more swelling.
Right, so we're not gonna attempt to ventilate, we just wanna visualize the cords to see what the swelling looks like.
What you gonna use? What you want?
So I think we had a fiber optic, we just wanna go straight through what you already have in place, visualize the cords, see if there's any way that, to
Your
attempt an
oxygen
airway.
is still at 81%.
I see the chest moving, so we have some air. So
Okay.
it's not a perfect fit. So as soon as we are maintaining that, it's not dropping any further. We can
wanna-
do some,
you have
but if
practice.
any deterioration,
Then we need to have an airway.
immediately.
Okay, we have a trick set up
Right
ready.
Ready.
Okay,
All right, so we can go ahead and have a look.
so we will, so but I don't really have what's name to look, but that's what we would do. We would look in, see what how much swelling or edema or anything is going on. The
Sacks
sac-
are dropping
Sacks are
70.
dropping. Okay, well, look, go ahead and, let's go ahead and prep the area real quick for your trade. Anybody got one stick?
There you go, right here.
Okay,
Put up red.
there you go.
Who's gonna be recording?
With Sheila, is recording.
Okay, so the prep is done, and I'm gonna use this one for the try. And then what size trick is it?
We have a 4.0.
4.0.
And I
What
need
size?
somebody, just We're giving drugs in case of an
We have
emergency.
drugs available. What would you like to prepare?
We prepare some epi, some ecoplasm.
All right, we got epi and we'll be ready for
So I'm
you.
giving a little bit of local, and is there another lady in there? So the incision is being made, I have an assistant somewhere.
Ryan.
Hold the track. Okay, cool. Hold the track, because I just need you to keep this open so that I can see. Remember that when I get down to the airway area, we cannot use the bogey at that point,
Yeah,
because
because
that
we
will
have to
increase
be
the
ready.
fire.
That's ready.
So I have visualization, let me see the two. Going in and pull your LA back a little bit, because I can't see. So I'm going through. I hold ventilations for a second, or turn the oxygen off for a second. You stop all our little bleeders, take out to the side.
Oxygen off.
Okay.
And that's not
Tray tube is in place, I'm tying it down. So we're connected to the tray tube.
Okay.
oxygen back on.
You want me entitled?
Tray
Yes.
tube is in
Entitled,
place.
Yeah, entitled. we have-
Oxygen is coming up,
Okay.
slow down. Oxygen is coming up.
Oh, that's good, I see good ventilation.
Still have a good power set.
Okay.
Yep, I have, still
We
have
set
pulse.
of 93. Okay, that's,
And do we have 911?
that's what I said.
911 here, right?
911 here.
We're waiting for you.
Okay, so let's go with what we
Alright.
have so far. We have,
Who's taking report? Who's 911? I can be 911.
Okay.
you are the.
Medic 675, what's going on?
So this patient came in for as well, and during induction, lost the air, could not ventilate, could not ventilate. This LMA was difficult, ended up having a trach. So procedure wasn't done. We transferred this patient to the nearest hospital.
Okay.
Ventilating okay at the moment. We're gonna put an OG tube to decompress the stomach because of all the ventilation. There was a lot of air in the stomach. And then we can take the patient. One of us will go with you.
Okay.
One of our ventilators.
All right, thank you guys. All right, we'll take it. Good job. All right, let's debrief.
Yes, so during the debrief, we'll talk about first what we did great, what we did right, and then after that would be opportunities. So anyone can speak? What do you think we did great?
So let's start with the team that was at the bedside. So we can start with the anesthesiologist, ENT, everybody. If you guys can, anesthesiologist, so what went well? You can point one or two points.
I think the biggest thing was the distance of the machine.
Good point, good point first. Let's talk about what went well.
What went well? Oh, what went well?
Yes.
What went? Oh, okay.
Don't beat up yourself. Don't try to beat up yourself first, okay?
I think
So-
everyone remained
I
really
think,
calm.
Yep.
Everyone was calm and clear communication, is what I saw.
Yep.
I saw that the anesthesiologist identified the problem right off the bat, and and asked for help, whether it was just the stuff coming in on that he needed, and or the next anesthesiologist. So I think that was.
And I think the suggestions from other staff, and we call 911, and sometimes I must admit we concentrate on something. Although the reason why we listen to the sound. Sound for us is very important. So that big of the AutoSat, sometimes we're not even looking at it, but we can hear the sound.
Mm-hmm.
So I didn't have it there, but it was good. Somebody was saying, "Oh, sound is dropping."
Yeah, so that's situational awareness. So whenever everyone is tunnel vision, working on the patient, if something changed on the screen, even if you don't know what's going on, but you see something change, just call it out. Say something happened to the monitor. That gives your leader to focus, and maybe that would change the whole course of treatment. So make sure, feel free to speak up. You can say, I don't know what happened to the monitor, but something changed. It was not the same that I saw a minute ago. So that will give them an idea of, okay, what's going on. Now we have to take care of the airway part. So that's good.
I think that you were I mean, obviously, so focused on the airway, but then Mel kept an eye on the monitor and the pulse at all times, just your like second pair of eyes, right, with that, so I thought that was pretty good.
Usually there is another default leader. So you have your anesthesiologist, that's already a defined leader, but you have a second person that actually help you go through that process as well. So that's good.
I think I like that.
Communicate with each other as well. I mean, I'm not a doctor, but I think he listened to some
Sounds
of the
like
stuff
it.
that the doctor beside him was saying, and he gave his feedback as to why he thought it was a good or bad idea without bumping heads about what the treatment should be.
Yeah, but you sound like a doctor though. Good job.
I said you play one. I never
Yeah,
did.
he played really well.
Is the quick
What
trade,
else?
is the quick
What
trade
else?
the preferential, is that our go-to now? Not the traditional trade? We going to the
So
quick trade?
the percutaneous
It's on the
is not the perfect. I think for an ENT surgeon, it's better just to go with the real trach rather than percutaneous.
So,
I like
so
that.
there is a difficult airway algorithm. Everybody aware of it? There is a difficult airway algorithm on the Diffcult cart. Are you guys aware of that algorithm? Because it really tells you exactly what you should be doing within 2 minutes. If saturation is not changing, what do you do? What are the second level of treatment that you can go on? So be familiar with that, and then remember, everybody is an expert in what you do, but when it comes to critical event, all those experts come together as a team. So you work as a team regardless. So I don't know your name. Richard. Dr. Richard may not know the Diffcult cart algorithm, but if you know, you can bring and work with him what's going on. Hey, this is what it says on the algorithm. We've attempted twice. The next course of action is this. And that would give you like a communication, but understanding of communication, right? So make sure you use the tools you have and be familiar with the equipment you have. So this is a very, it's a well done algorithm, and it has all the algorithm up front, but at the back it gives you exactly what happens every 2 minutes, what is the saturation and what can you do. So make sure you familiar yourself with this, and then it really guides you through this type of process.
We should probably, I don't know, re-educate everybody on that algorithm. I don't know how we can do that, but maybe we can do that over the next week or so.
Okay.
But I think everybody, it's a refresher.
Yeah, you don't do this thing every time, so forgetting is okay, but it's okay to cheat. If something happened and you know it's a difficult airway, and you know this document exists, that's the time where you can cheat. Nobody's asking anyone to memorize this, but you need to know where it is, where it lives, and then when you get it, how you read it through it.
This is very similar to like our algorithms that we have on the code card.
Yes,
you know,
exactly.
patient,
Just like the ACLS.
ACSV algorithm, tachycardia, SPT. So we have all those algorithms, and this would be really good.
Yep.
It is. It's a cheat sheet. We can't all remember what's going to happen next, but these really help.
Yep.
I didn't realize either. I think it's a good idea to make sure everybody understands.
You know, on Monday, there was something I did notice, or I heard your patient had taken the Cinepril. And from what I know about the Cinepril is, and this is coming from my primary care, is that a lot of African American patients have an allergic reaction to a Cinepril, and it doesn't necessarily start the first time you use it. It can start any time. It happened to me. I woke up, my lips were swollen, I thought my throat was swelling. Luckily for me, I ran and grabbed some Benadryl and called 911, and they took me to the hospital. I was fine. And I'm not sure if that was possibly the case with this young lady, but I heard that she had taken the Cinepril as a part of her morning meds, and maybe that, including the stress, may have had a triggering effect. But I know we have a lot of patients that come in with the allergy already listed that they're allergic to the Cinepril. It's something that I noticed.
Yeah, that's a theory that I think after discussing as a team, because somebody could be taking it for a long time,
Right.
and then one day they just
all of a sudden,
right.
it triggers
Can
something,
be
stressor triggers it.
can start off slow and then suddenly accelerates. I mean, we've had one at the hospital lots of patients that needed awake intubation or some ended up in
That
trach.
is correct.
So that was a theory because I think her tongue was large, which made it difficult for the LMA to sit properly as well.
But whatever the cost would be for a difficult airway, as long as we know our protocol, our workflow, our algorithm, we would save a life. Because this has already been established. But it's not set in stone. What I mean is if it says there after 4 attempts, you can proceed to plan C or D if need be. You don't follow that just because it's written. So you can escalate it and jump over to the farthest plan to save that patient.
I think Dr. Mawowo was very well spoken when, like me playing the doctor was saying, well, let me look at the chords. He was like, but I think any other attempt at trying to ventilate could cause further swelling and we would lose the airway completely. So I'm recommending going straight to the trach.
Right.
So I remember we used to have a trach tray on the card. I know that we have the quick trachs, but has that been deleted from the card, from the difficult intubation card?
Did you guys use it the other
Trach
day?
tray?
We brought one in from
Regular trach. Is it an SPD? Where's it
It's
got?
an SPD.
They have it,
They
right?
use it the other day.
And I think your question is valid because I'm not familiar with that, and I don't know that ENT is. They were very familiar with the trach tray because they needed the dilators, they needed the hook.
Yeah, they use the Shivey last time.
So,
So should that be on the card?
That's something that they could use, like in packing or something on the fly, you know?
I think
We used
it's,
to keep them on card.
when it's not ENT, that would be the goal to go to the percutaneous. So yeah, we need it on the card.
Can they both be on the card? Or is it not?
I think that's just the percutaneous because if we call ENT, then at the same time somebody has to bring the open trach kit.
We were trained. Wouldn't you use, in ACLS for us, we were trained to crack. Wouldn't you use that at all in case that?
I think in our
So if you
situation,
yeah.
I was gonna say, in ACLS, with the way we're trained, is, and I'm referring this back to what happened on Monday. You have your experts at bedside at hand, you know, like ENT was there. So when we use a crike, that would be like when we don't have any of these extra resources.
Right.
Then our go-to would be, okay, let's get the crike open. You know what I'm saying?
Which, I mean, if you do not have ENT
Right.
on hand or anything with anesthesia, would use that as well.
Right.
Even though when you have the ENT, usually the crack is the first choice
Yeah,
because
that's what-
it is percutaneous, it's faster performed, it's less invasive, and also less probability to create any damage. A tracheostomy will take time, and you don't want them to be rushing through. In that case scenario, you have to buy time. That would be the perfect equipment to buy time, and then allow them to do a definite solution, which is the trach at that moment, to go ahead. But we do have the trach here.
You do?
But the thing is, like, most of the time, people are not familiar with it either.
We have it in the code part.
Yeah, but they're not familiar by doing the procedure per se.
Oh,
They don't
anesthesia
feel
is not.
comfortable. So
Oh, no,
I'm
we-
not
we-
saying
we
that
do.
to move over, but I know that some people have experience. Oh, I never
Gotcha.
did one during my training,
Got
something
it.
like that. You know what I
Okay.
mean?
Yeah.
But this is a crack,
That's what I know.
and it's a percutaneous. It's just
It's
stick here,
thick, yeah.
localizing airway,
Uh-huh.
dilating,
Yeah.
advancing. That's it.
I think you guys are going into opportunities, which is good, but a couple things with the simulation, you guys made it, the patient survived, so that's a good thing. But if you go into opportunities, a couple things I want to mention. When we had an incident in DCSM, and we've done this throughout DCSM, a couple of the questions that came up, maybe if it's in your mind, I'm just going to bring it up. So when anesthesia go in, look and come out, some people think that that was an attempt, but it may not be an attempt. It's just looking and coming out, looking and coming out. So the algorithm calls for 2 attempts before you proceed to invasive protocol. So as part of team dynamic, the anesthesiologist, when they look, they can say, I'm looking, I'm not attempting. And they can give you that verbal discussion where you will know, okay, they're not really attempting, they're just looking to see if they can advance or not. But then if they say, I'm attempting the first one, it didn't work, I'm attempting the second one, it didn't work, then you guys should go into the next level of action, which calling ENT, calling 911, whatever the actions are that was outlined here. So what I want to point out is, if you don't know whether they're looking or actually intubating and attempting, ask that question. Are you okay with it? Are you attempting, or are you just looking? So those questions really help to make sure that anesthesia and the rest of the team are on the same page. It's called the same mental model. So then you don't really question what's going on. So make sure you understand that part. And then the other piece of information I want to know, if you need ENT, do you guys have the phone number? Do you know exactly to call them, and would they be available for you? If not, it should be part of your process to make sure that you have that phone number available for you.
Or at least overhead paging.
So you're overhead paging,
You can
okay,
pay
okay,
overhead page, correct?
okay.
And it's on here.
And ENT is all day here.
It's on the list.
You have an ENT doctor throughout the day.
Yes.
Okay, all right.
And not necessarily.
But for the purpose of the simulation, Dr. Gupta was ready to come down.
I just have a question. If ENT is not available, should we attempt to call pulmonology? Because they should be able to intubate really well.
Yeah, but not.
I don't know, is that the process?
No.
Because
Anesthesia
as
can
far
do
as
it.
intubation goes, you have anesthesiologists here who can do it.
It's general surgery will be second.
Yeah.
General surgery should be able to do it.
Urology is last.
That's a good one.
Had to leave the room, he brought up
All right.
an issue during the scenario on Monday, was the kidney restless?
Correct, it was down, it wasn't in place, so it created a
It was
void.
not in place.
A void was under the patient where compressors were being done. And that wasn't something that I picked on when I came in, but I did notice that she was at an angle, but I wasn't for sure, but I did ask the question, is she tilted? Is she tilted? I didn't get an answer.
Yeah, she had a wedge
Yeah,
behind her.
and I was gonna say they're flat if it is, but I didn't get an answer, so I just did with compressions until, the compression part wasn't needed anymore. Then I noticed she was at a wedge and it wasn't.
And like I said, the other concern that was raised during our meeting, this debriefing, is that anesthesia couldn't, with the machine, and the TIVA was placed in a fashion that she felt like she couldn't reach the machine to ventilate the patient. So what do we do about that? Is it education? Is it moving the table differently before before the patient is intubated and then move the table? What do we do? Jason, I brought up your kidney rest issue, you talked about that a little bit already, but now we're talking about the placement of the table.
I think that's the issue. When I first came here, I was shocked how far the anesthesia machine was from the. I know it depends also which side, but
So should there be a tech for the induction for these cases? So there's two people, someone who can, theoretically, anyone else in the room can, but maybe there should just always be, since they can't have both hands on the patient and the machine at the same time, just at the beginning of the case, there should be someone there.
that's possible. But sometimes we have, like in the morning, one tech that's so it's a bit tricky.
Or maybe to have a
You
second
need your
doctor.
schedule, so it just make a note that, okay, we need, the tech needs to be, these are never fly by, let's just throw it as well.
Do you mean the SBAL tech or the?
No, the anesthesia tech.
Is it not safe to move this med after it's been locked? Is it too difficult to start out the way we normally do with the anesthesiologist up there and the patient head of the bed, and then once the patient is intubated or has a good airway, then spin the table?
Well, part of the thing is also, we check to make sure we can see the stone, all of that while the patient is still awake. So it's not that you can't, but then it may be a matter of having to kind of reposition, kind of do all of that.
My question is, can the anesthesia that's on wheels, can it slide towards the head, even though it's over there? Can it be moved forward to within arm reach of everything?
I don't think that too much because of all the wires that come from the ceiling.
The boom, does the boom move back?
It's a boom, right? What about the table itself?
There are times when the table is the other way, right, perpendicular. I don't know why sometimes it's one way versus the other, but if
So
it's,
when we have the system, I usually have it perpendicular, so you have.
so you gotta remember that, okay.
Yeah. So that's when I usually have it the other way.
So, Dr. Willett, so if the table was like that, you still can't do the X-ray before we use?
No, you mean if the table was turned
Yeah.
the other way? No, you can,
It's the left side as well, it's the right side.
if it's the right side.
You can't.
Should we?
Can the
Okay,
table
what
move
about doing- could we
like
do
this way toward the
legally
wall
before-
so that the head's closer?
come into the OR?
No, it's not about the KUB, it's about the fluoro, being able to see it. I mean, yeah, with the KUB, ideally you can see it, but they change the stone shifts. I mean, I don't know if it's worth having your patient.
But the thing is, like, I can say this, like, it doesn't matter how you have the table, because with LMA, anything can happen at any time. You might be perfect with induction, everything might be okay, and then still you turn the table, everything is okay, but at some point there, the LMA move or whatever, and it's
So what
gonna
do
be
we
the
do-
same
What would
thing.
we do in that scenario? Let's say we're turned and then we've now lost the airway.
You can still turn.
What do you do?
But sometimes it's not depending on the table position or anything else, it's other factors. Even when the table is normal, sometimes the LMA dislodge and move, and then they lose the airway. That happens all the time, normally with SBAL, with any procedure, even when the table is in the right position.
I think the issue with this table is that we can't turn it.
No, the thing is, like, they couldn't turn it after the problem ensues. If we can, like, then remodify the position to assist the patient in a more effective way, that was the issue. But still, there were, like, how many people there? We could move the machine, somebody was ventilating, somebody was taking care of their airway, still the problem is there. I mean, it's not a problem of the table per se.
I mean, the table can move, it wasn't moved.
We did move it.
I mean, eventually,
You did,
but yeah,
We did move it.
but it wasn't, yeah, I feel like the
I see.
table itself wasn't,
Is it maybe it's just,
at some point it will be farther away than,
Yeah.
when there can be two vents, but it can be moved
now,
back.
if you get into a situation where you're concerned and you need to be back to the machine, we just need to ask you to turn the table back?
Table.
Is that the solution that,
Yeah, I think so. I think, so it can move 45 degrees. Okay. And that's the issue because, Julia is right, it can happen anytime, but those tables are easy, we have the control.
You can simulate moving it. The only issue is just moving the cords out of the way.
Okay.
But it's pretty easy.
Because sometimes things can happen quickly. Patient can have spasm and you want to back and so things can happen very quickly so that you need a very quick response. But
I'll show you the table.
sure,
Alright, so it's pretty simple. There are 3 boxes on the table, 2 here, 1, 2, and then 1 lock in the back. This is the steer. You pick it all the way up, that's steer, neutral, lock. But other than that, we just had to unlock the bed and we moved it closer to the bag. We had that shit.
you can go ahead and move it.
We just pushed it, moved the cord down a little bit, and pushed it closer to the bag.
So Jason, for all, like, whenever you have that kind of event, you're always in the case assisting, right?
And can you turn it
Yeah, you
on
can
right now?
always, they can always come to you and say, Jason, let's move the bed really quick and, matter of getting closer, so.
You can turn it like
So
that.
ideally, the bed should move pretty easy.
Easier than our table, actually, it doesn't weigh anything.
Yeah.
So another
So
thing,
maybe it's just increasing the awareness that these tables can be moved rather easily, is that?
it does. I'm very putting effort on it.
But you're comfortable in starting this way and making sure you have an airway? You're okay with starting this way?
Yes, I think I'm okay with starting that way, and the other plan B is, personally, I think I would suggest if the anesthesia tech is available, to be around.
Yeah.
To help.
I think that's a good idea too. Thank you.
And it's not possible all the time, but if they're available, they can come in and
For
help
these
with it.
cases especially, yeah. I think that's a great call out.
And I'm gonna piggyback one more time, so I know I mentioned moving the machine, and I do know that they're tethered to the walls, but when they're tethered to the walls, there's a certain amount of slack that's given to it, so you can move it, the machine itself. So if you're up there and you want to be able to reach, the machine actually can be pushed for a certain length towards where you are, so just another thought.
Yeah, I would move it for different cases.
Yeah, we do.
I think we'll look at that too. We'll have a look at that.
I need to go soon, but one thing I thought could be helpful, I don't know if there's a checklist for everything that needs to happen, like calling 911, calling ENT, having the trach, so that there's someone who's like responsible for the checklist saying, because random people were saying, oh, we need to call 911, and someone else said, hey, what about ENT? But there was a centralized person who had like the checklist of all the things, and it's not necessarily an order, it's just, have these things been done, you know, is ENT in the building, you know, even before, you know, someone thinks about it, just having everything there.
Like assigning the scribe, assign
Yeah.
somebody to.
Exactly, assigning
the algorithm,
roles,
right?
like just someone to like, this is your clipboard to keep it all running smoothly, make sure we're not missing anything.
I agree with you. I think the only thing with this is we need to have some, like, you know, we have our simulations a couple of times a month or a couple of times a year. I think we need to have this often, a little bit more, because then that definitely gets us thinking. Just like I was saying, you know, we need to press that button where we can have the PACU team respond, right? And typically when in that setting, when a PACU team responds, they essentially take over, you know, to help with the run the code. But still, with that said, you have several other team members that, you know, okay, the more we do this, the more to think like, okay, well, the lead, hey, I'm gonna call 911, just like you said, you know, I'm gonna call ENT, what else can I do? Like, just kind of run down everything, and maybe nobody's paying attention. Oh, guys, here's the, you know, algorithm for the airways.
Yeah.
So I think just having consistent and at least having all of us participate will definitely help us kind of thinking in that manner as well. Because I think that's a great idea.
God forbid there's like two at the same time, because that
Yeah.
can happen. And then the person who like, you know, if you have less experienced people,
Yeah.
like myself, it's like, you know, it's like, I'll man the checklist. Because you just, you know.
I do think we should have, at least every quarter, we should have a mock code. Because it's just like a reminder. I did not know we have that algorithm on that difficulty airway card. But I guess if we do it like once a quarter, everybody's gonna be more up to speed. I know when I take the ACLS class, the first few months after that, like I'm really good at it. After that, it goes less and less. So I don't know.
And the other question that was asked, I wasn't there that day, but when it was overheaded, I think, was that overhead serious enough for
It
people to run?
was, so no, it said second anesthesia to OR1.
Right, I heard.
Us as managers responded because we're like, oh my God, why do you need a second anesthesia? And just to make sure. But you didn't find any other members of the team responding because it didn't, you know, when you say, I guess it's also the way we say it, you know, need help in room 1, or just along those lines, you know.
Could we just use stacked?
To stack, because then that kind of gets everybody's ears
Right.
popping like, okay, do we need to respond? And then the other thing is each room has that code blue button, right? That code blue button can be heard everywhere on our OR side. In the pre-op PACU OR, so that alerts everybody even more, okay, well, they definitely need help. Like, then you'll find an abundance of people rushing in there to help you with that.
I think I like the stats.
I like the stack, definitely. Yeah, because that'll get you, because it could be just, you're just having a difficult time
Yeah.
just placing the tube, or just, so you just need a second anesthesiologist. You don't need a whole team responding to you, So.
And that's what I felt like when I heard the call. I just thought maybe but at some point you can escalate from that because it might have just been all you need was some extra eyes. But once it gets to the point where you know what, I'm gonna need this, I'm gonna need this, then just go ahead and hit the button because then you're gonna have everybody come in.
Is it better to overhead anesthesia or call the phone?
I would say overhead anesthesia because sometimes these guys, when you call the phone, they could be talking to the patient. Although they do a really good job, even when they're talking to patients, still pick up. But you don't know what situation that might be in. So you might be attempting to call 5711 a couple of times, whereas overhead page, anesthesia, stat, room 1. So
that means that even people that are maybe on a short break will stop, which is what happened. I understand.
Well, another point that Asha made this morning regarding matters of differing opinions on how to proceed, and the staff feeling about being shut down when they were suggesting or recommending something. Well, she said the mental makeup of an anesthesiologist is I can do this, but then you have to be cognizant at some point that I can no longer do this. I need help. So that's when you call out for help. And because in this difficult the airway issues, we don't have much time. It happens so fast, most especially in pediatric cases. So.
Respiratory arrest can then also lead into cardiac arrest.
Right.
So I think although anatomy of the anesthesiologist is that you're focused on your airway, and it's good to have that second leader that was in there to say, oh, we can't feel a pulse now. Can we start compressions? That was the one thing I know that one of my PACU nurses kept saying on Monday, I don't feel a pulse, I don't feel a pulse. She said that I think about 3 times before we started compressions because we don't feel a pulse. And I feel like that wasn't okay, but the blood pressure is good. But we're so fixated on that airway, but it's like, so all of us, just have to be good about listening to each other and saying, okay, wait, let me feel for a pulse too, and make sure that that patient does have one. If not, we need to start compressions right away as well.
Anything else?
I think, I think you're talking about that, 1 attempt, 2 attempts. The problem with us, when 2 other anesthesiologists come in, let me try also.
Yeah.
Right.
And then the third one comes, let me try it. By the time.
And just to give you guys history, this happened years ago, and as a result, patient expired. They've attempted for an hour and a half while ENT was in the room holding his hand like this. So the goal is, this is developed by the med group and health plan team, and this is an algorithm that's everybody agreed upon. So it's very good if everybody knows it, and when health plan is making suggestion or your support team is making suggestion, it's something that's driven from the algorithm. So from a physician standpoint, I know you can do it. I know you're trained to do it. This is what you've gone for school and you've done it so many times. We get that. But if there is a process in which you can follow and have that communication, then you'd be like, okay, you know what? I have attempted a couple times. It didn't work for me. I don't know what's going on. But even if another anesthesiologist comes in, I've attempted, and the algorithm calls for invasive procedure. So let's move on. Let's make sure that we secure this airway for this patient. So guys, just, this is your Bible for that procedure. So try to use it. And when it's modified or revised, then that would be the next one to use. So again, it will help everyone to stay on task and have the same language. All right.
Great job so much.
Thank you. And I've